Hello, my name is Kathy Schilling, and I am a radiologist and medical director at the Center for Breast Care in Boca Raton, Florida. As a radiologist, I have spent a great deal of my career researching new imaging technologies in the area of breast cancer. In the past 2 years, I have focused most of my research efforts with positron emission mammography, otherwise known as PEM. PEM is an organ-specific high-resolution PET scanner that has high accuracy in detecting breast cancers. PEM has been studied extensively since 2005 and proven to demonstrate a high sensitivity and specificity. Currently, our clinic at the Center for Breast Care is involved in a multi-center trial comparing the accuracy of PEM and breast MRI in newly diagnosed breast cancer patients. We are also conducting a similar independent study which involves women with newly diagnosed breast cancer who are anticipating breast-conserving surgery. The purpose of this study is to determine changes in surgical management resulting from PEM or MRI imaging as compared to conventional imaging using histopathology as the gold standard. Currently, we have 160 patients enrolled in the study, and I would like to take a moment to highlight a couple of these cases to demonstrate how PEM changed the surgical management of these patients. Case number 1 is a 63-year-old postmenopausal woman with known invasive lobular carcinoma in the right breast. She was imaged on both PEM and MRI prior to definitive surgery. MRI did not find any suspicious enhancement in the right breast and recommended a 6-month follow-up for scattered tiny cysts. However, a 5mm indeterminate nodule was visualized on the left. Centrally, an MR biopsy was recommended. In contrast, PEM found a 13mm irregular mass with increased FDG uptake in the right breast, and there was no suspicious finding in the left breast. This is an example where PEM confirmed the invasive cancer with no false positive finding. Surgical planning resulted in a bilateral mastectomy showing low-grade 14mm invasive lobular carcinoma in the right breast and benign fibrocystic changes in the left breast. Case number 2 is a 58-year-old postmenopausal woman presenting with suspicious calcifications on the right breast mammogram. An MRI was done pre-biopsy and indicated BI-RADS3, probable benign findings. PEM was performed post-biopsy where a lesion was seen on the right breast. Pathology diagnosed high-grade DCIS in the right breast. Once again, PEM accurately detected the lesion. Case number 3 is a 48-year-old perimenopausal female with known invasive ductal carcinoma in the left breast, imaged on both PEM and MRI for preoperative staging. MRI showed the known malignancy in the left breast and an indeterminate mass on the right, recommending an ultrasound and biopsy considered BI-RADS 4B. PEM showed FDG uptake in the known malignancy in the left breast and no definite abnormalities on the right breast. Final pathology diagnosed a left breast total mastectomy with an 18mm invasive ductal cancer and right breast mastectomy fibrocystic changes. In this case, PEM accurately predicted the final surgical pathology. These cases are indicative of the challenges with MRI, the false positives, and the difficulty interpreting the images. In my clinical experience, PEM has demonstrated significant advantages over MRI in certain clinical situations. Not only are the images clear and distinct, but PEM shows both functional and metabolic activity and therefore is easier for the physician to interpret. In our clinic, we conduct over 65,000 breast exams annually and routinely apply PEM as a part of our patient protocol. PEM is changing how we identify and treat breast cancer, and I strongly believe that it will continue to be an integral part of our breast cancer protocol for the future.